Hi, my name is Bill Pagin Hsieh. I'm a cardiologist currently practicing in Southern California. It is my pleasure today to present to you a research study we conducted at UC San Francisco and presented at AHA in 2008 and published at the International Journal of Cardiology. The title of the study is "The Amplitude Ratio of the First to Second Heart Sound is Reduced in Left Ventricular Systolic Dysfunction." Disclosure on the study was supported by HT Medical Group. As we know, early detection of left ventricular systolic dysfunction is critical for prevention and management of heart failure. However, thus far, we do not have available a tool at the bedside that allows rapid and cost-effective diagnosis of asymptomatic left ventricular systolic dysfunction. Several phonocardiographic parameters, such as the systolic time intervals, detection of third and fourth heart sounds, has been found to correlate with left ventricular systolic and diastolic dysfunction. However, the sensitivity and specificity for identifying left ventricular systolic dysfunction specifically are inadequate. In animal studies, we know that the amplitude of the mitral component of the first heart sound is proportional to the rate of left ventricular pressure rise, or otherwise known as DBDT. This property had not been extensively studied in applying humans because previous studies did not use modern method of left function measurement for reference, and an optimal calibration method was not available. But more importantly, a phonocardiographic device in general was not widely accessible and is usually bulky and not easily performed. To address these shortcomings, we sought to study heart sounds in using an innovative digital phonocardiographic device in patients who had either invasive or non-invasive measurements of left ventricular systolic function. And we hypothesized that the amplitude of S1 corrected for S2, or otherwise is known as the S1 gradient, reflects left ventricular DBDT and ejection fraction in human subjects. We recruited consecutive patients referred to UC San Francisco and San Francisco VA Medical Center for a left heart catheterization with their clinical indication. We included patients who were in sinus rhythm, have physiologic heart rates, native valves, and we excluded those with moderate or severe valvular disease, or patients who were in shock, had severe systemic hypertension, or primary pulmonary hypertension. We enrolled 70 subjects, and we had to exclude 9 subjects because of significant fluid shift during the cardiac catheterization. They were defined as positive or negative fluid balance exceeded 1 liter, and variation of 20% of blood pressure or heart rate after the cardiac catheterization. Within 2 hours after the left heart cardiac catheterization, each of the 61 patients underwent simultaneous phonocardiogram, electrocardiogram, and echocardiogram. The studies were performed by 2 independent investigators. One performed the phonocardiogram and EKG, and the other performed the echocardiogram, each blinded to the result of the other investigations. The Viscope, a portable digital phonocardiographic device with capacity for simultaneous ECG recording, was used to record heart sounds. 20 seconds of continuous phonocardiographic recording was obtained from each of the 3 standard auscultatory locations: the apex, the left upper sternal border, the right upper sternal border. Raw heart sound data were post-processed with a frequency bandpass filter of 20 to 100 hertz. The amplitude of the first heart sound was defined as the largest deflection seen within the heart sound component that follows the QRS complex. And the S2, the amplitude of the second heart sound was defined as the largest deflection seen within the heart sound component that falls between the first heart sound and the next QRS complex. The mean S1 and S2 amplitudes were obtained by averaging across the number of available cardiac cycles, which was about 21 cardiac cycles. And we also studied measurement variability and found that both the intra and the inter-observer variability fall within 10% of the overall mean amplitude. Ejection fraction was obtained from each of the 61 subjects from echocardiogram using biplane method of disc. And estimation of pulmonary arterial systemic blood pressure was available in 29 subjects. All echocardiographic measurements were independently cross-examined by a second investigator. We had a total of 47 subjects who had DBDT available, and 39 of which had the value derived from the rising slope of the mitral regurgitant velocity spectral envelope obtained from continuous wave Doppler. 8 subjects had DBDT measured directly using a catheter during cardiac catheterization. 14 subjects did not have the DBDT available because of inadequate mitral regurgitant jets, or the intracardiac pressure recording was not available because the catheter did not cross the aortic valve during the catheterization. So what did we find? When we divide the group into those with normal DBDT defined as 1,000 or greater millimeter mercury per second, and those with those with reduced DBDT defined as less than 1,000 millimeter mercury per second, we found that the absolute amplitude of the first heart sound at left upper sternal border was significantly decreased in the low DBDT group. And the S1 to S2 ratio at both the at left and upper sternal borders were significantly decreased in the reduced DBDT group. This is also not surprising that we see that the blood pressure was also significantly reduced at the reduced DBDT group. Similarly, when we compare with the group with normal ejection fraction defined as the ejection fraction of 55% or greater, we found that those with reduced ejection fraction had decreased absolute amplitude of S1 at the left upper sternal border, and decreased S1 to S2 ratios at both the left and right upper sternal borders. And in addition, those with reduced ejection fraction had lower blood pressure, higher heart rate, and tend to be older, which are not surprising. To display these findings on box plots, we see that at the left upper sternal border, the overall S1 to S2 ratios were actually significantly lower in the group with reduced DBDT compared with the normal DBDT group. And similarly, the S1 to S2 ratio, the mean S1 to S2 ratio of the group with reduced ejection fraction was significantly lower compared with the group with normal ejection fraction. This correlation between decreased left ventricular function and decreased S1 to S2 ratio was not observed in at the apical location. I'm sorry, the next one, the apical location. On a logistic regression model, after adjusting for systolic blood pressure, heart rate, BMI, and PR interval, we found that increased S1 to S2 ratio remained independently predictive of normal DBDT and normal ejection fraction. On ROC curve analysis, S1 to S2 ratio recorded at the left upper sternal border and right upper sternal border, but not the apex, significantly discriminated normal from decreased dBdt and ejection fraction, with the areas under the curve being greater for S1 to S2 ratio, discriminating normal from decreased dBdt, compared with S1 to S2 ratio, discriminating normal from decreased ejection fraction. You can see the areas on the curve are different between the two groups. Using different cut points, we found that the best diagnostic accuracy could be obtained by using S1 to S2 ratio of 1, where we see that the sensitivity of S1 to S2 ratio of greater than 1 obtained at the base of the pericardium, of the pericardium for detecting dBdt of equal or greater than 1,000 ranged from 72 to 80%, and the specificity ranged from 57 to 71%. Using the same cut point, the sensitivity of S1 to S2 ratio for detecting normal ejection fraction ranged from 74 to 80%, and the specificity ranged from 54 to 61%. Several study limitations have been mentioned. Number one, majority of dBdt were obtained by Doppler echocardiogram. We only have few dBdt that were obtained from cardiac catheterization. Because we know that the Doppler method of estimating dBdt using mitral regurgitant velocity spectral envelope on continuous wave Doppler has been well validated in previous studies. The likelihood of misclassifying left ventricular systolic function is probably low. And secondly, in those who had dBdt measured invasively, the phonocardiogram was not obtained simultaneously with direct intracardiac pressure recording. We attempted to address this issue by excluding those with significant fluid hemodynamic shift during the cardiac catheterization to minimize any potential discrepancy in hemodynamics before and after the cardiac catheterization. Thirdly, the largest positive to negative deflections in the first heart sound component was assumed to correspond to mitral component of the first heart sound. We believe that this assumption is valid because we have taken measures such as excluding artifacts by applying a frequency bandpass filter, and in addition, we also ensured that our study population did not have patients who had tricuspid stenosis, obstructive right atrial mass, or large ASD that could potentially increase the tricuspid component, the amplitude of the tricuspid component of the first heart sound. Lastly, changes in second heart sound could independently alter the S1 to S2 ratio, which can confound the interpretation of the ratio. We attempted to address this issue by excluding patients with shock or severe systemic or pulmonary hypertension to effort to keep the S2 as constant as possible. So in conclusion, at cardio-based S1 amplitude and its ratio with S2 amplitude, or we actually call it the S1 gradient, are reduced in LV systolic dysfunction. As the S1 gradient discriminated normal from abnormal left ventricular systolic function. The ratio of 1 of the S1 to S2 ratio may be used as a cut point for screening for left ventricular systolic dysfunction. And lastly, handheld digital phonocardiographic device appears promising as an adjunctive bedside tool for evaluating left ventricular systolic function. Thank you.